Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're going to be doing another Kahoot, and we're going to be going over neurological disorders. Before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it, so go ahead and give it a thumbs up now. Subscribe to my channel if you haven't done so already, and be sure to check out my website, nexusnursinginstitute.com. You can sign up for a Next Generation NCLEX review, Part 1, Part 2. You can also sign up for private tutoring sessions, consultation sessions. If you're a current nursing student, you're not studying for boards, you're just really trying to survive the program. I have audio lessons, so be sure to check that out by going to my website, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my social media platforms, such as TikTok, Instagram, and Facebook. My handle's the same everywhere, Nexus Nursing. Without any further ado, guys, let's get started. Neuro. We're going to be covering neural concepts. All right, so the patient with Bell's palsy has an inflammation of which cranial nerve? When we're talking about Bell's palsy, which cranial nerve is affected? Is it cranial nerve 5, cranial nerve 6, cranial nerve 7, or cranial nerve 8? What do you guys think? Okay, most of you guys got it right. Cranial nerve 7, the facial nerve, that's the one that's affected. Your patient has a halo external fixation device in place because they had a spinal fracture. Which intervention would be appropriate for this type of patient? Would it be to ensure that the weights are freely hanging? Would it be to remove the vest at bedtime? Would it be to perform pin site care? Or would it be to loosen the pin slightly every day until it naturally falls off? What is the most appropriate nursing intervention for a patient with a halo external fixation device? Wow, 44 of you guys chose ensure that the weights hang freely. All right, so guys, think about the fixation. I think you guys just saw fixation. I'm assuming that's what you guys saw, but this patient's not having any, it's not traction. There are no weights, right? If you see the picture that had the halo, it's these 4 screws that are attached to the skull, okay? And it causes, what's the word I'm looking for? Alignment's not the word I'm looking for, but for immobilization. It causes immobilization of the spinal cord. There are no weights. So I think you guys were thinking about, traction and weights. There are no weights for the halo for the halo device. The second one, remove the vest at bedtime. Absolutely not. Let me tell you something. The neurosurgeon decides when this thing comes off, excuse me, and the patient's going to have it on for weeks and months. All right. So we're not removing anything at bedtime. And loosen the pins slightly. No, actually, you're constantly going to be assessing your patient. You're going to be assessing those pin sites. And if any of them are loose, you're going to report it immediately. That is something that you absolutely have to report, but you are not going to be loosening it unless you want to lose your license and get sued. What you're going to do is perform pin site care, because this is, and obviously I just told you, it's for screws, there's screwed to your skull, right? So this is something invasive. So the patient's going to be at risk for infection. So you're going to be assessing the patient for signs and symptoms of infection. You're going to be performing pin site care to prevent infection from happening. Again, this device, you want it to stabilize and immobilize the spinal cord. When the nurse performs a physical assessment on the patient with Bell's palsy, which symptom is most expected to be found? Is it quivering of the eyes, muscle spasms of the upper extremities, loss of lower function in the legs, or unilateral facial paralysis? Very good. Unilateral facial paralysis. So as we talked about already, when it comes to Bell's palsy, the seventh, that facial cranial nerve, that's what's affected. So what happens is those nerves in the face, the muscles, they're flaccid. And so when the patient tries to smile like this, when you smile, right, it's supposed to be bilateral, that you could see the symmetry. You see this person smile. If you blow out your, like this, blow out your cheeks. Did I say that right? You go like this. You'll see it both sides. Well, the person with Bell's palsy, the side that's affected, if they try to smile, only one side will go like this, and then you'll see that paralysis on the other side where they can't, smile. Their lip won't go up. They can't blow out their cheek. The whole side, that whole side of their face is basically we'll see flaccid paralysis because the muscles are just so weak. Which nursing intervention is most appropriate for the patient with Bell's palsy? Oh, we got a lot of Bell's palsy. All right. What nursing intervention is most appropriate? Is it to dim the lights in the room? Is it to teach the patient to drink liquids through a straw? Is it to assess the patient's buccal pouch for food after eating? Or would you teach the patient how to walk with a cane? What do you think would be the most appropriate nursing intervention for the patient with Bell's palsy? Very good. Assessing the patient's buccal pouch for food after eating. Well, remember, I just told you one side of their face is weak, right? So even them chewing or swallowing, that may be a problem. And our biggest concern is going to be airway. We don't want that patient to aspirate, because if they have that weakness on that side of the face where the food is, they're not chewing properly, they didn't swallow, that food is just collecting right here, they might have a chance for aspiration. And who cares about walking? Who cares about drinking? Who cares about light? Who cares about anything if your patient's not breathing, right? Airway, breathing, circulation, airway always comes first. That's going to be your priority. Your patient with sciatic nerve pain is scheduled for a myelogram. Which instruction takes priority? Is it part of this test involves a lumbar puncture? You will have to change positions often during the test. Dye will be injected into your vein, or you'll be sedated with anesthesia. Okay. 27 of you guys chose dye will be injected into the vein of your arm. Guys, how many times have I said this to you? If only part of an answer is correct, the whole thing is wrong. You saw dye and you jumped on it because you see myelogram, that end of the word, gram. When you see gram, you're going to think of contrast media. You're going to think of dye, right? But we're talking about myelogram. And is that dye injected in the person's arm, in their vein? Are we looking at the vessels in the arm? Absolutely not. That dye, where it's going to be injected, we're going to see in the spinal column, because that's what we're actually looking at. So that's wrong. The correct answer, which 19 of you guys chose, is part of this test involves a lumbar puncture. Now, wrong answer choices, you'll have to change positions often during the test. You won't. What happens is the patient's going to be on this table, and the table will move as the healthcare provider needs it to move for visualization, and you'll be sedated with anesthesia. No, the patient will not. They will be awake. So the correct answer is the test does involve lumbar puncture. Select all that applies. Your patient just had a discectomy and spinal fusion. Which would be included in your teaching? Select all that applies. Here are your choices, guys. Avoid twisting motions of the back. Sit in a chair with a soft back. Avoid sitting for long periods of time. Bend at the waist when picking up objects. Report pain that's not relieved by rest or analgesics. Notify the healthcare provider if drainage is clear or blood tinged. Select all that apply. Your patient just had a discectomy and spinal fusion. What are you going to teach them? So you see discectomy. Whenever you see that word ectomy, that means removal of. So they remove part of that a spinal disc, and they fuse it back to they fuse the bone back to the rest of the spine. So that's what's happening. What are you going to teach a patient about? Okay, let's talk about it. Let me move this. Avoid twisting motions of the back. Absolutely. They just had this procedure where, like I said, one of the discs were removed and then they fused it back. Why would that patient be doing twisting motions? Absolutely not. So you're going to teach them that, true. Avoid sitting for long periods of time. Absolutely. We want the patient to get up, move about, ambulate. We don't want to put pressure on the back, especially the lower portion. Report pain that is not relieved by rest or analgesic. Well, why do you think we did this discectomy in the first place? So after the patients had this procedure and the patient's having pain, and that pain is not being relieved by rest, it's not being relieved by analgesics. You want to know what type of pain that is? That's called persistent pain. Okay, persistent pain is when a patient has a pain that continues despite what evidence-based practice measures has shown us should relieve it. Okay, so that lets us know there's a problem here. So those are good teachings that you're going to provide. Now, what's wrong? Telling the patient to sit in a chair with a soft back? No, you're going to teach them to sit in a chair with a straight back. Telling them to bend at the waist when picking up objects? Absolutely not. You're going to tell them to bend what? At the knees, right? And then notify the healthcare provider if drainage is clear or blood tinged. What color is the drainage supposed to be, right? You expect the drainage to be clear or blood tinged. Now, here's where you're going to be concerned. You're going to be concerned if that drainage is what? Purulent. Anytime a patient has had an invasive procedure, we're always going to be concerned about these three things. You're going to be concerned about them developing a clot, thrombosis, emboli, pulmonary embolism. You're going to be concerned about hemorrhage, bleeding out, right? And the third thing you're going to be concerned about is infection. So you'd be worried about purulent drainage. You're teaching a patient with a herniated disc. What teaching is most applicable after symptoms are relieved? Is it to carry objects away from the center of gravity? Is it to lift with your knees bent and your back straight? Is it to create a base of support by keeping your feet together? Or is it to select a soft, spongy mattress for your bed? Okay, the correct answer, lift with your knees. Lift with your knees bent and your back straight. You don't bend your back. You want your back straight, but your knees bent. That's the correct answer. Everything else is wrong. Carrying heavy objects away from the center of gravity. You know what that's going to mess up your center of gravity. You're going to mess around and fall, right? So you want to carry objects towards your center of gravity, not away. Creating a base of support by keeping your feet together, again, you're going to mess around and fall. If you want to create a base of support, you're going to separate your legs, right? And select a soft, spongy mattress. Nope. The mattress has to be what? Firm. How are you guys doing on the live? Okay, immediately after surgery, you note that the patient's dressing is moist. What is your first nursing action? Is it to change the dressing? Is it to reinforce the dressing? Is it to remove the dressing? Or are you going to document the findings? What are you going to do? Your patient just had surgery. Doesn't matter. It doesn't matter what type of surgery. They just had surgery. And you see that the dressing's moist. What is your first nursing action? Wow. Only 7 of you guys chose reinforce the dressing. Okay, well, let me make this absolutely clear to you. When a patient has surgery, that first dressing change has to be done by the surgeon, not you. Okay. So what you're going to do when you know drainage, you're going to assess, you're going to look, and you're going to make sure you document the amount of drainage, the color, was there any odor, what the skin looks like around the dressing site, but you do not change that dressing. The surgeon has to change that dressing. Now, what you're going to do is reinforce the dressing until the surgeon gets into the room and is able to change the dressing. So you can reinforce it, but you never remove it and you never change it. That is a job of the surgeon. Anita said maybe more tape. Yep. Adding more tape that could reinforce the dressing. Yes, but you never remove it. Very good. Which option correctly describes the outcome if ICP is untreated and it progresses? For those who don't know, ICP stands for increased intracranial pressure. Well, I guess it's ICP, but anyway, ICP, intracranial pressure. If the patient has increased intracranial pressure and it's not treated and it actually progresses, what would the outcome be? Displacement of brain tissue, increased cerebral spinal circulation perfusion, increased serum pH, or improved brain tissue oxygenation. Very good. Displacement of brain tissue. All that pressure is building up in the skull. Guess what? The brain's got to go somewhere. And so what happens is that brain ends up being herniated. Okay. And that causes irreversible brain damage. And this is what we're trying to prevent when we do all those measures to decrease ICP. Select all that apply. Which drug classes are most likely to result in falls? Benzos, opioids, glucocorticoids, anticonvulsants, antihypertensives, or Professor D, I have no clue. All right, what drug classes are most likely to cause falls in the patient? Select all that apply. Guys, I'm sorry, my live froze for a minute. My daughter's spam calling me. I put it on focus, but she doesn't care. Sorry. Okay. Very good. Definitely benzos, benzodiazepines, they can cause drowsiness, they can cause dizziness. You teach a patient when they first start taking this medication, their body's not used to it yet, not to operate heavy machinery, right? Opioids, absolutely. Opioids can lower the heart rate, it can lower the respirations, it can lower blood pressure. It can cause drowsiness as well. So that can result in falls, especially in older adults, right? Remember, the older adults, their liver and their kidneys just don't function the way that it used to. So when it comes to those opioids, they're at risk for opioid toxicity. Okay, a buildup in their body a lot quicker because they're not excreting that drug like they used to because of the kidney, and they're not metabolizing that drug like they used to because of the liver. Anticonvulsants. Absolutely. Think about what anticonvulsants do. If a patient has seizure disorder or they're epileptic, you have all this overfiring of those neurons. They're getting anticonvulsants to bring everything down, right? So anticonvulsants absolutely can cause drowsiness. It can cause dizziness. It can put the patient at risk for falls, absolutely. And antihypertensives. Antihypertensives bring down the blood pressure, but remember, it can cause orthostatic hypotension. If that patient's been sitting down or lying down and then they get up too quickly, what happens to the blood pressure? It drops and boom, patient's on the ground. So be very careful. Make sure you know that these drug classes absolutely can increase the patient's risk of falls. Glucocorticoids, no. Now, let's talk about glucocorticoids for a minute. Even though they don't increase the risk of falls, we're still concerned about glucocorticoids because, number one, they're very sugary. They can cause hyperglycemia. You'll mess around and turn your patient to diabetic, right? So if your patient's on steroids, you're going to be checking their blood sugar. But also, something else about glucocorticoids, they're hard on the stomach. So you know you're going to give it with food. We don't want our patient to get a stomach ulcer. What else do you need to know? Oh, You got to watch the patient very, very, very closely when they're taking glucocorticoids because it can mask the signs and symptoms of infection. So you're going to be looking at the WBCs. You're going to be looking at the temp much more closely, right? If there's a wound, you're going to be checking the wound site more often. And the fourth thing, osteoporosis, glucocorticoids can make the bones porous, and that can end up putting the patient at risk for falls down the line if they end up getting obviously osteoporosis, but it can make the bones very porous. So that's something else to be concerned about if the patient's taking this drug class for a long time. But generally speaking, it doesn't increase the patient's risk for falls like the other options do. All right, one more. All right, your patient was in an MVA, motor vehicle accident, and they sustained brain trauma. You suspect a complication of diabetes insipidus when observing what? Would it be hyperglycemia? Would it be large amounts of urinary output? Would it be elevated urine-specific gravity? Or would it be decreased level of consciousness? What would make you suspect maybe this patient is experiencing diabetes insipidus? Very good. Large amounts of urinary output. I'm so happy. Only 7 people fell for it and they went with hyperglycemia. Guys, diabetes insipidus has nothing to do with diabetes mellitus. When we're talking about diabetes mellitus, that's when their blood sugar is too high. With diabetes insipidus, that's when the patient is not, their brain hasn't released enough antidiuretic hormone. Maybe antidiuretic hormone isn't being made enough, right? But here's the thing, this patient got an MVA and they sustained brain trauma. Well, what's responsible for secretion of ADH, antidiuretic hormone? The posterior pituitary. Where's the posterior pituitary? In the brain. So think about it. If that posterior pituitary is affected, the release of ADH may be affected. If the release of ADH is decreased, you're going to see large amounts of urinary output because antidiuretic hormone is what makes you hold on to all your fluids, right? But if you don't have enough of that, you're like Oprah Winfrey, you're giving it all away. You get urine, you get urine, you get urine, everybody gets urine. And here's the crazy thing. This patient is releasing these large amounts of urine, but the urine specific gravity is very low. Why is that? Because all the solutes is not in the urine, they stay in the bloodstream. So even though the urine output is up, the urine specific gravity is down. Why? All of those particles stayed in the blood. And that's why the serum osmolality is what? Up. Because all of those particles are what? In the blood, not in the urine. So hyperglycemia is wrong because we're not talking about diabetes insipidus. Elevated urine-specific gravity is wrong because if anything, the urine-specific gravity is going to be down, right? And then last, a decrease in level of consciousness. I'm happy only 3 people chose that. The decrease in level of consciousness, we very well may see that, but we would see that because of the head injury, not specifically diabetes insipidus, because this question said you'd suspect a complication of what? Diabetes insipidus. So seeing a decreased level of consciousness, that could just be to the brain trauma. But when we're speaking specifically about diabetes insipidus, you need to be thinking about the posterior pituitary. You need to be thinking about antidiuretic hormone. You need to be thinking that the antidiuretic hormone is down, which causes urine output to be up, which causes urine specific gravity to be down, and serum osmolality to be up. Guys, you have to know what goes up and what goes down. If you're in a nursing program, you have a test coming up, I promise you're going to get at least one question on that. So make sure you understand it and you know which way the arrows go. And that is it for this Kahoot. Let's see how you guys did.